Assalamu alaikum doctors, welcome to my YouTube channel MBBS and BDS lectures. Today is the 19th video of prepared revision course of operative dentistry, which is very important for NAD exam, MDS and BDE as well as for final year students. And this video is important for operative dentistry, endodontics as well as for periodontics, dental trauma. Now in this video we cover the whole this chapter, dental trauma. Now we will discuss about dental trauma, its types and its management in detail. First, the general rule is not all cases of trauma need intervention, some only need follow-up. Not all cases of trauma need intervention, some only need follow-up to wait. Now note, when a patient come with a trauma and there is indication of RCT per that tooth, we should postpone for 10 to 14 days, because when we do excess opening, if tooth is already mobile and we do cleaning and shaping and remove the pulp during excess opening and pulp extirpation, the tooth will be more mobile. Therefore, first we apply splint on that tooth, or if there is first we apply splint, then after 10 to 14 days we call the patient and then do root canal treatment. When RCT is indicated in a traumatized tooth and tooth is still mobile, excess cavity and pulp extirpation will cause more trauma to the PDL. If RCT is indicated, pulp extirpation can be postponed for 10 to 14 days. Now the question is that why do most dentists make wrong decision in dental trauma cases? There are two reasons. Number one, it is hard to determine the priority and which trauma to be treated first, since most cases include more than one type of trauma. For example, Coron fracture plus root displacement plus alveolar bone fracture. Then the decision is difficult which fracture should be treated first. Second, trauma is not a regular case which dentists deal on daily basis. Therefore, dental trauma cases dentists make wrong decision. Now, because teeth are hard tissues, injury appear as a fracture. In soft tissue, there is injury appear as a laceration, but because teeth are hard tissues, injury appear as a fracture. Now, first we move from visible portion up to crown, then the root, then alveolar bone. First, crown fracture. There are three types of crown fracture. Incomplete, which involves only the enamel, not dentin, not pulp. Second is the uncomplicated fracture. It involves the enamel plus dentin but not the pulp. Third is a complicated fracture. It involves enamel, dentin and pulp, both, all three. This is the Coron fracture. The types of Coron fracture, there are three types: incomplete, uncomplicated and complicated. Now come to the root fracture. Are all complicated fracture. Root fracture are all complicated fracture because they always there will be pulp involvement. So next is the crown root fracture. There are two types. Again, crown root fracture. Uncomplicated involve the enamel plus dentin plus cementum. Complicated fracture involves the enamel plus dentin plus cementum and involve the pulp. This is about crown fracture, root fracture and crown root fracture. Now come to the trauma classification. Trauma classification. Trauma to tooth we classify into 6 types. First is the Coron fracture. Second is the Coron root fracture. We move from visible portion of tooth toward the roots. First is the Coron root fracture. Second type, first is the Coron fracture. Second type is the Coron root fracture, mean both Coron root fracture. Third is the only root fracture. And fifth is the periodontal ligament injury. And sixth is the injury to the soft tissues. There are we classify the trauma to teeth into 6 types. Now, then in each type there is a subtypes. First is the Coron fracture. In Coron fracture there are 2 types. One is incomplete Coron fracture. Second is the uncomplicated, mean 3 types in Coron fracture. Incomplete Coron fracture, then uncomplicated Coron fracture, and then complicated Coron fracture. First is the incomplete fracture, also known as Coron infraction. In incomplete fracture or Coron infraction, just a crack in enamel or enamel chip off, usually no loss of tooth structure. Here only crack in the enamel or some enamel chip off, but there is a no loss of tooth structure. This is incomplete fracture or Coron infraction. Second type of Coron fracture is the uncomplicated Coron fracture. Here fracture confined to the enamel or might involve dentine but no pulp exposure. Look at the diagram on the left side. The pulp is not exposed and fracture involve enamel and maybe dentine. Now come to the complicated Coron fracture. Look at the diagram. In complicated Coron fracture, the pulp chamber is involved and pulp is exposed. Fracture involves enamel and dentine plus pulp is exposed. This is the 3 types of Coron fracture. Now come to the Coron root fracture. Here the Coron is fracture and also root is also fracture. Here there are two subtypes of Coron root fracture. One is uncomplicated Coron fracture, second is complicated Coron fracture. In uncomplicated Coron fracture, fracture involve enamel plus dentine plus cementum but no pulp exposure. But in complicated Coron fracture, fracture involve enamel plus dentine plus cementum plus pulp exposure. Now in Coron root fracture there is a addition of cementum. Now come to the root fracture. Root fracture is always complicated fracture. Mean there are one type of root fracture. These are complicated fracture. Mean in every root fracture the pulp will be exposed. Fracture involve dentine plus cementum plus pulp. Classify based on into 2 types. Number 1, location of the fracture, where we classify the root fracture on the 2 bases. Number 1, on the location of the fracture, where fracture is located, coronal, middle or apical third of root. Second is the presence of displacement of the coronal fragment. Either the coronal fragment is coronally displaced or lateral displacement, mean coronal fragment, crown part, upper part of the root. This is about root fracture. Now come to the periodontal injury, ligament injury. Then periodontal ligament injury, these types of trauma to teeth are divided into 4 subtypes. Number 1 is the concussion. These are very, very important biennial exam. Number 1 is a concussion. Here in concussion, the trauma energy that reach the root is very low. No clinical finding at root level. The only sign is that tooth is tender to percussion. When we percuss the tooth, there will be pain. Might be seen with a Coron fracture, maybe Coron fracture. No displacement or loosening of the teeth. Mean in concussion, there is a concussion is a mild form of trauma to the PDL. but there is a no displacement of tooth and no mobility. But tooth is tender to percussion. This is about concussion. Now come to the subluxation. Subluxation is slightly more severe trauma than concussion. In subluxation, the traumatic energy that reach the root is low but higher than concussion because it is slightly higher than concussion. Abnormal loosening, mobility plus no displacement. Here again, tooth is tender to percussion plus bleeding from gingival crevice. Now, what is the difference between concussion and subluxation? In concussion, there is a mild form of trauma to pedial and tooth is tender to percussion but no displacement, no mobility. But in subluxation, the trauma is slightly greater than concussion and there is mobility plus no displacement. Displacement is not present, but mobility is there. And also tooth is tender to percussion plus there is a bleeding from gingival crevice. Third is the luxation. In luxation, the tooth there is mobility plus displacement, and luxation is more severe form of injury than subluxation. Now, luxation of come to the types of luxation. There is two types of luxation. One is intrusive luxation. Next is extrusive luxation. In intrusive luxation, the tooth move apically and tooth displaced because there is a mobility plus displacement and tooth is displaced into the alveolar bone. This is intrusive, and in extrusive there is a tooth is partially out of socket in axial direction. Look at on the right side diagram. In intrusive luxation, there is a no pedial space and tooth is firmly attached to the socket and tooth is in intrusive form. But in luxation, there is a more pedial space and tooth is longer than adjacent crown and tooth are in the axial direction. Now in intrusive, tooth displaced into alveolar bone always combined with the communication plus minus fracture of the alveolar socket. There may be fracture of alveolar socket. Clinically, the crown is shorter than adjacent tooth. When we see the tooth, the crown of this tooth is shorter than adjacent tooth. If all four interior are at the same level, mean intrusion of both central incisor. If all four interior are on the same level, mean there is an intrusion of the both incisors, central and lateral. Now come to the extrusive luxation. Partial displacement of tooth out of socket in an axial direction. Tooth is usually either protruded or retruded, mean in labial or in lingual direction. Clinically, the crown is longer than the adjacent tooth. How we diagnose the clinically when we check inside the patient mouth, the crown is longer than adjacent tooth. Now come to the last type of periodontal injury, which is avulsion. In avulsion, the tooth is completely out of socket. In avulsion, complete displacement of tooth out of the socket. If patient tell you I could not find the tooth, take a periapical X-ray. It may be case of complete intrusion, or patient swallow it, take chest X-ray. But the tooth is completely out of socket. Look at diagram on the left side. The tooth is completely out of socket. Now come to the next type is the injury to the supporting bone. Next type is the injury to supporting bone. Now there are four subtype of injury to supporting bone. Number one is the comminution of the alveolar socket In comminution of alveolar socket, there is crushing plus compression of the apical part of the socket. The apical part is compressed as well as crushed. It is not a real fracture, always found with intrusion. When there is a comminution of the alveolar socket, there will be compression and crushing of the apical part of the socket, and it is not a real fracture, but always found with the intrusion because tooth will be intruded in the socket area. Second type is the fracture of the alveolar socket wall. Look at diagram on the right side. The alveolar socket wall is fracture. Here the fracture of the facial or lingual socket wall always found with lateral luxation. When wall fracture, the tooth will be moved in lateral luxation. Mean laterally displacement. Either in facial or lingual direction depend upon either facial or lingual socket wall is fracture. Can be found with avulsion. It may be avulsion of the tooth. Next is the fracture because when there is a more displacement, then there will be avulsion. Next is the fracture of the alveolar process. Alveolar process is fracture. Fracture above the apical part of the socket. Above the apical part of the socket, if there is a fracture, may or may not involve the socket, there will be fracture of the alveolar bone. Open associated with occlusal interferences, there will be occlusal interferences. Several teeth move together. When you push the central, the other central plus lateral will be moved. Mean there is a several tooth move together because above the alveolar bone is fracture. This is a sign when we check clinically. Next is the fracture of the jaw. Fracture involves the base of the jaw, often involve the alveolar process with or without socket fracture, and it is treated by oral and maxillofacial surgery. Now come to the last types in classification, injury to the soft tissues. There are three types of injury to the soft tissues. Number one is the laceration. Laceration is a deep wound or tear resulting from sharp object. This is laceration. Next is a contusion. It is a bruise. Mean in bruise there is a submucosal hemorrhage result from a blunt object. No break in the mucosa. No break in the mucosa, but there is a bruise, red spot area resulting from the blunt object, and this is a submucosal hemorrhage. Next is the abrasion. There is a superficial bleeding wound result from rubbing or scrubbing of the mucosa. When mucosa is rubbed or scrubbed, there will be abrasion. When there is a deep wound, there will be laceration. When there is a blunt trauma, there will be contusion. Next, trauma is mostly seen in children. Most common seen at the age of 2 to 5 years when they start walking, and at the from 8 to 12 years when they start playing sports. These are the two peaks of trauma of children. And trauma is more in boys than girls because boys are more active in sports activity and mostly go to with friends. Therefore, they also interested in fighting, and in the result there will be trauma. Now come to the dental trauma. Till the point we discuss the trauma and trauma types, mean classification. On the basis of classification, we study 6 types and their subtypes. Now come to the dental trauma management. First is the general guideline for trauma management, then each types and its subtypes management. First, in dental trauma management, there is a first is a general guideline for trauma management. There are 8 general guidelines for trauma management. Number one is the provide psychological support to the trauma patient and take history, examination and assessment help you establish priorities. Mean with the help of history, examination and assessment, you will be able to which trauma is serious first, or which type of trauma we should treat it first. We treat first. Second is the second guideline per general guideline per trauma management you can do in every types of dental trauma. Second is the control of bleeding and pain is your first priority. In first priority, you should control bleeding and pain. Third is the protection. Third is the protection like pulp protection up to root surface protection. For example, during repositioning. If repositioning is required, you should protect the root surface, should not touch the root surface, because on the root surface there is a growth factor, and you hold the tooth from the crown and reposition the tooth. Fourth is the repositioning. Repositioning of teeth, bone or soft tissue, reposition in that area. Fifth is the stabilization. Fifth step is the stabilization. Means stabilize the reposition area when we place teeth or bone on the previous site or soft tissue. Then you should stabilize that separated parts of that area in order to they do not move. Bone and teeth, by how we stabilize? By help of splint. It may be rigid or flexible, but how we stabilize soft tissue? By sutures. Sixth general guideline is the temporary restoration. If a patient aesthetic is affected, then we should give a temporary restoration like temporary crown. Maybe a priority if aesthetic is affected. Seventh is the medication. Then there are two types of medication. Number one, systematic. Number two, local. Systematic like tetanus injection, because if patient fall on the roadside, there will be more chances of tetanus, and in the sports ground. Next, we should give systematic antibiotics, analgesic and anti-inflammatory drugs. Next is a local. In local on that tooth area, we should give intracanal dressing inside the root canal, then chlorohexidine gel and mouthwash for oral hygiene. And the last eighth general guideline for trauma management is a follow-up. We should keep the patient on the follow-up in order to see their improvement. Now come to the after general guideline for trauma management. These guidelines are for every types of trauma. Now come to the specific, mean for each type of trauma, what will be our management. First is the management of complicated and uncomplicated Coron fracture. First, management of uncomplicated Coron fracture. Management of uncomplicated Coron fracture means the root is not exposed. We should protect the dentine. With the help of, we give simply restoration or crown. This is the management of uncomplicated Coron fracture. But next is the complicated fracture. Then we have two types of teeth. Number one is mature tooth. Second is immature tooth. Management of complicated Coron fracture means pulp is exposed. If teeth is mature, then we go for RCT. If tooth is immature, then we should preserve the pulp by three methods: pulp capping, if exposure is small. If exposure is more, then pulpotomy. It may be partial or cervical. And third is the, if trauma is more, then we go for partial pulpectomy. Mean we remove the superficial pulp. Now come to the management of Coron root fracture. Mean Coron and root both are fracture. To know if Coron root fracture is complicated or not, First, remove fragment plus take radiograph or CBCT, cone beam computed tomography. Now come to the uncomplicated crown fracture management. Then complicated crown root fracture management. First is the uncomplicated crown root fracture management, mean there is a no pulp involvement. First, remove the mobile fragment and clean the area. Then suture gingival laceration if present. Third, GIC place an exposed dentine site above gingival level. If you cannot replace GIC immediately, you can do it maximum after 24 hours. Expose the margin of the fracture by gingivectomy or crown lengthening or orthodontic extrusion. Fifth is the permanent restoration. If no time or until definitive treatment plan is made, a temporary stabilization of loose segment to adjacent teeth is done. This is the management of crown root without pulp involvement. Now come to the complicated crown root fracture with pulp involvement. Then there are two scenarios. Number one is the if tooth is non-restorable, go for extraction. If tooth is restorable, restore the tooth. Simply. Now come to the management of root fractures. Management of root fractures. In management of root fracture, protection of pulp tissue and pedial is not applied because tooth is already exposed. Because we know all root fracture are complicated fracture. Then for management of root fracture, number one, reposition the tooth with digital pressure if needed. Second, suture the laceration area if present. Third, apply flexible splint in root fracture for 4 weeks if mobility. Then follow up after 6 to 8 weeks, then 6 months, then 1 and now follow up after 6 to 8 weeks. Then next follow up is after 6 months, then after 1 year, and then after 5 years. Now come to the management of concussion and subluxation. Remember, in concussion, no mobility, no displacement. But in subluxation, there is no displacement but mobility. Mean tooth is not displaced in buccal, lingual, apical or coronal direction. Now first, concussion management. In concussion, mean there is a tenderness to percussion from concussion may not occur immediately. It may be delayed for few days. Mean there tooth will be tender to percussion from concussion may not occur immediately, but it may be delayed for a few days. RCT can cause tenderness to percussion sometime because it disappear after 3 days. When we do RCT, there is a patient is tooth is tender to percussion, but it disappear after 3 days. Concussion does not require any treatment, but if severe discomfort, you can reduce the tooth from occlusion a little bit and follow up to 1 year. I mean, in concussion treatment, concussion required no treatment. If there is a when patient bite, there due to pressure, patient feel pain on that specific teeth, we should reduce the tooth from occlusion. Mean from the crown we should remove slightly enamel and should place the teeth out of occlusion. There will be no pressure. Mean this tooth will be not take part in occlusion. There will be no pain per patient, and but for MCQ's point, concussion have require no treatment. And follow up, we should keep the patient for follow up to 1 year. Second is the subluxation. Also subluxation, usually no need for treatment because there is slight mobility, no displacement. A flexible splint per patient comfort up to 2 to 4 weeks plus soft food for 1 week and oral hygiene. Mean if patient is not comfortable for patient comfort, we place a flexible splint up to 2 to 4 weeks plus soft diet for 1 week and oral hygiene and follow up to 1 year. Next is the mean concussion and subluxation required no treatment. Now come to the management of luxation, and luxation are of two types: extrusion and management of extrusion or lateral luxation. If either teeth is mean extruded in coronal direction or lateral luxation mean into mesial, distal, apical or a closal direction. Now the management of extrusion and lateral luxation. First, management of what are the similarities between extrusive luxation and lateral luxation? There is a both have percussion sensibility negative, sensibility test negative, but in radiograph there is a in radiography enlargement of apical periodontal space because tooth is displaced either in extrusion or lateral luxation. There will be enlargement of apical periodontal space. Now the difference between extrusion and lateral luxation is in extrusion there is a excessive mobility plus exposure of root surface. Root surface is exposed. In lateral luxation there is a high metallic sound plus no mobility because it is contacting the bone. Mean in lateral luxation there is no mobility, but in extrusion there is a mobility. Why in lateral luxation no mobility? Because the tooth contacting the alveolar bone. But in the lateral luxation there is a high metallic sound. Now in management steps of extrusion and luxation, lateral luxation. First is the rinse the exposed part of root surface with saline before positioning. Second step is the apply a local anesthesia, especially for lateral luxation. Why local anesthesia? Because there will be pain. In lateral luxation, the socket valve will be fracture. Third, reposition the tooth with your fingers. And fourth is the flexible splint for 2 weeks for extrusion and 4 weeks for lateral luxation because it is mostly associated with bone fracture. And keep the patient on follow-up up to 5 years. Initially in lateral luxation or extrusion, we do not do RCT. First we stabilize the teeth unless there is a necrotic pulp. If pulp is necrotic, then we should go for RCT. Now come to the management of intrusion. Mean tooth is in intrusive luxation and tooth is displaced apically. In intrusion, first on percussion there is a high metallic sound but no mobility. Sensibility test usually negative. Radiography, no periodontal space. When we take radiograph, there is a no periodontal space. Like in lateral luxation and extrusion, there is a more periodontal space. But here is, look at on the diagram, there is a no periodontal space. Both intrusion and lateral luxation have the metallic sound on percussion and no mobility. This is the main point. Both lateral luxation and intrusion have high metallic sound and no mobility because tooth is displaced into bone. Now come to the after sensibility test. There is a tooth looks shorter than adjacent tooth. When we check the tooth in occlusion, it will be shorter than adjacent tooth. If tooth looks shorter than adjacent tooth, then considered an emergency. No need to start a definitive treatment right away. Now in immediate treatment for intrusion, there is a soft food for 1 week plus brushing with a soft brush and rinsing with chlorhexidine 0.1%. Follow up to 2-4 days, then 6 to 8 weeks, then 6 months, then 1 year, then yearly for 5 years. In definitive treatment for intrusion depend upon stage of root development and intrusion level. To know how much the root got intruded, you can take a cone beam computed tomography or compare it to the level of the adjacent tooth. The treatment option is the spontaneous repositioning. Leave the tooth and watch and wait. The tooth will become to its position spontaneously. Second treatment option is the orthodontic repositioning. We reposition the tooth by orthodontic appliance. Third is a surgical repositioning. We uh, we move the tooth in the position by surgery. Now, how we choose surgical repositioning, orthodontic repositioning, and spontaneous repositioning? It is depend upon the level of intrusion. Either it depend upon the root of tooth is close apex or open apex, and the level of intrusion. First, if tooth root apex is open, then we check the level of intrusion. If level of intrusion is up to 7 mm, the management will be spontaneous repositioning. Leave the tooth, watch and wait. The tooth will become itself into position. If because in open apex the tooth is in developmental phase, meaning children, the tooth will be growth are present, the tooth will become spontaneously. If the level of intrusion is more than 7 mm, then we go for orthodontic or surgical repositioning. Both will be give same result. Either orthodontic or surgical. Decision depend upon the fate of the patient want the treatment. Which type of treatment patient want, both give the same result. Now come to the close apex case, meaning adult. It depend upon again level of intrusion. If up to 3 mm, there will be spontaneous repositioning. If 3 to 7 mm, orthodontic or surgical repositioning. If more than 7 mm, only surgical repositioning. Now come to the RCT. Complete root. Now in RCT, if there is a complete root formation, mean close apex, do RCT. In intrusion case, probably be initiated within 3 to 4 weeks post trauma or 2 to 3 weeks post surgery. Now in RCT, after cleansing and shaping, you cannot obturate immediately. You need to place a long session calcium hydroxide. Now come to the incomplete root fracture. Mean in close apex we do RCT, and in open apex only do RCT if there is evidence of pulp necrosis. Otherwise, there is no need of RCT in incomplete root formation. Now come to the management of the last part is the management of avulsion. Tooth is completely avulsed out of socket. Now in management of avulsion, best management of avulsion is to re-implant the tooth immediately after avulsion. Immediately after avulsion, re-implant the tooth. You can rinse it for a few seconds under running water and then re-implant, but washing should not exceed 10 seconds. We can wash by water for a few seconds but not exceed than 10 seconds. First aid that can be done by anyone around the patient. Anyone around the patient, they can provide a first aid before they can come to the dentist. In first aid include there are 4 steps. First is calm the patient down. Second, hold the tooth from a crown and wash it briefly under running water for a maximum of 10 seconds. Do not hold with a root surface because there is a growth factor and there is a PDL. Third is ask the patient to bite on a handkerchief to hold the tooth in a position. And bite on the handkerchief. Place the handkerchief over tooth and ask the patient to bite on to hold the teeth in position. Fourth, seek emergency dental treatment or hold the tooth from the crown, place in suitable storage. Medium and seek emergency dental treatment. Now, when we place In fourth step, seek emergency dental treatment, mean go to hospital. If there is no emergency treatment near patient area, then hold the tooth from crown and place in a suitable storage medium and seek emergency dental treatment. Best to worst storage medium is the best medium for storage is the culture media, then milk, then saliva. Keep inside the mouth in the cheek. In how we place in saliva? Keep inside the mouth in the cheek. Mean tooth keep inside the mouth in the cheek. And last is the saline. Mean the best is the culture media and last is the saline. Teeth should never be placed in water. It will cause lysis of the epithelial cells. Now these storage medias are very important because MCQs come from that. Always in last NLE exam there was MCQs come from per storage media. Now storage media per owl's tooth. In storage media, first medium is in table there is a medium and characteristics. First is the water. Do not use water for storage media. Why? Causes repeat lysis. Do not have the correct osmolarity. Only a quick rinse if nothing else is available. If nothing else is available, give a quick rinse to remove the debris from the tooth, but not then more than 10 seconds. Next method is the saline. Tooth can be kept for maximum 1 hour. Do not contain nutrient for the cells. Therefore, only tooth can be kept for maximum 1 hour. Next is the saliva. Tooth can be kept for maximum 2 hours, but not more. Why? Contain a lot of bacteria. There is a risk of infection. Next is the milk. Tooth can be kept for maximum 6 hours. Has suitable pH and osmolarity. Do not use yogurt or soy milk because pH is too low and not suitable. Next is a tissue culture medium. Tissue culture medium is the best to use, but it is rarely available because the solution has kept at 4 degrees centigrade. Tooth can be kept for 4 days. Next is the best one is the next is the HBBS. What is HBBS? Is the Hank's Balance Salt Solution. This is the best one and can be kept at room temperature. This MCQ was come in previous NLE exam. Now here the sequence will be the best one is the HBBS, then culture media, then milk, then saline, saliva, then saline. Now, how to save a tooth? Half filled with HBS and contain either a basket or chamber to limit the tooth mobility and reduce the chance of damage to the cell. This is all about today lecture trauma to teeth, and we cover the every aspect of trauma, and this chapter is very important for operative, endo and periodontics. Now in this playlist there is 18 videos are already available. Go and watch these videos also. If you like my videos, press the like button and share this video with your friends. If you are new to my channel, subscribe my channel by pressing the red subscribe button and also press the bell icon in order to receive my each new video notification. For watching my videos, I am very thankful to you. Thank you very much.